the slides. And what I would like to do is I'd like to come across to my colleague Julia Russell, who many of you know on this call. Julia is our Clinical and Quality Improvement Manager at Hospice UK, and is our lead for the Patient Safety Programme. And thank you so much, Julia, because you've been doing a lot of the work here today with our Patient Safety Forum, but also in terms of supporting hospices with questions around how we are learning together and going on this journey of implementation. So thank you so much for all the work you've done and for getting us started. And I know you wanted just a couple of slides because we may have colleagues who are not from hospices today joining us. And so, Julia, can I hand over to you, please?
You can. Thanks, Anita. Hi, everybody. It's so nice to see so many familiar faces on the call today. Really delighted. And as Anita said, thank you, Amber and Stuart in the background. And a massive thanks to Claire. I'm sure it's going to be great. No pressure. But I just wanted to have a couple of slides for people that might not be that familiar with Hospice UK, just as a wee refresher, just to let you know what we do and who we are. So we're the national charity for hospice and end-of-life care, and we're working to ensure everyone affected by death, dying and grief gets the care and support they need when they need it. And just onto the next slide, please, Amber. So what do we do? Just as, I mean, some of you will know this already, but we work with over 200 hospice members across the 4 nations. Obviously, today is not applicable in Scotland or Northern Ireland, but across the 4 nations, we do lots of work. Working with governments and local communities, supporting our hospice staff through training and peer support groups. We run lots of national knowledge sharing networks and our echo sessions on dementia and prisons and education, patient safety. We've got a brilliant online innovation hub. If anybody hasn't seen it, I'd highly recommend just to have a Google search and have a look at it. And obviously we've got our Dying Matters campaign and Compassionate Employers. And obviously we're celebrating Hospice Care Week this week as well. So just a wee refresher about Hospice UK, and as I say, delighted to have you. So I'm going to hand over to Claire. This is the main event today, Claire. And as I say, thank you so much for coming along. And so Claire's a policy manager at the CQC and knows about lots of different things about PSIRF. And I'll let you properly introduce yourself, Claire, but I'll hand over to you. Thank you very much indeed.
Thanks very much, Julia. So, yep, my name is Claire Land. First, I'll say apologies if you see me glancing here. My Teams bit is down here, so you're all down here, but my notes are here, so I'll try not to be looking around too much. Really a great opportunity to come and speak to you about PSIRF and what that particularly means to CQC and our regulation and assessment. So I know we've got pretty much the whole hour to cover this, so hopefully we'll have a chance to get into some discussions and some of your concerns about PSIRF as part of that. If you could just move on to the next slide. So just kind of that I'm going to try and cover 5 main areas. So firstly is how PSIRF aligns to CQC's strategic ambitions, with a bit of context setting there. Secondly, implications for the hospice sector, and I guess this is my first caveat, which you'll see on the sort of that I'm a policy manager in acute, so that will cover the acute and ambulance services. For example, you may or may not be more aware with one of my colleagues, Helen Hayton, who's the policy lead for hospices. But as the PSIRF lead, and in order to try and reduce the amount of duplication in how we work, I'm leading on PSIRF from a cross-sector perspective, which has been very interesting. I've got to learn lots about sectors that I didn't know a huge amount about, and just how wide PSIRF's reach is. Actually, I did a session earlier this week with the health and justice sector, for example. Thirdly, then, is to kind of speak through how PSIRF fits into the new single assessment framework and the new regulatory approach, which I think will hopefully, as well as being able to describe PSIRF, will, I think, hopefully describe the single assessment framework in practice as well. Then to speak specifically about CQC's oversight role. And then lastly, kind of a bit of a Q&A, what are your concerns about PSIRF and so on. And then I guess that's where my second caveat comes in, and I think I'll say this more than once, which is this is a learning journey for CQC as well. We don't have all the answers right now, so there may well be some questions that you ask me that I'm not able to give you a definitive answer right now. Obviously, it's a huge change for us as well as you there actually out there implementing it. If we could go on to the next slide. So as I said, I just wanted to spend a little bit of time speaking about our strategy and how we see that PSIRF supports that. So it's actually over 2 years ago now that strategy was published, so we can't really say it's a new strategy anymore, but it recognises the fact that the health and social care landscape has changed drastically since 2016, which was when our previous strategy was published. Obviously, those changes in the sectors have been accelerated by the pandemic. And our role as the regulator was also greatly impacted by the pandemic. We weren't able to go out and inspect all services in the way that we normally do. And so a big part of our strategy is around our new regulatory model, our new single assessment framework, and changing the way we regulate. So just to give you kind of a brief overview of the 4 main themes, which are shown in the 4 quadrants of this diagram here. These themes are all interlinked. The first is about people and community, so regulation that's really driven by people's needs and experiences and focusing on what's important to people and communities when they access, use and in particular move between services. The second area is smarter regulation. So this is the one where you will probably feel this most, because this is where the new regulatory model fits and the new single assessment framework. So it's that ambition to have a more flexible approach to regulation that isn't so inspection driven, where we can use evidence collected from a variety of sources to make more up-to-date judgments. Currently the only way we can publish a report and change a rating is if we go out and carry out an inspection, and actually there's quite a lot of evidence we can use that doesn't require that on-site presence. The third one, safety through learning, is really where PSIRF fits most neatly, and this is about regulating for stronger safety cultures across health and care, and so I'll come back to that one on the next slide as well. And then the 4th theme is around accelerating improvement, so really helping services access support to help improve the quality of care where it's needed most. And then cutting through these four themes are kind of 2 cross-cutting ambitions. So one around health and care systems. So you might be aware that we've been given the duty to assess integrated care systems, and those kind of pilots are just starting to roll out now. And then secondly, reducing inequalities as kind of one of the cross-cutting themes that covers all of that. So if you could just go on to the next slide. I'll just speak a little bit more about safety through learning in particular. So there are kind of 5 main areas to safety through learning. So one is around culture. We know that having the right organisational culture is crucial to improving safety. And that means it's got to be a top priority for all, regardless of seniority or role. That people who use services can play their part in that. And obviously PSIRF really picks up on that element. And that issue that in a strong safety culture, risks aren't overlooked or hidden. Staff can report honestly and openly and be confident that they're not going to be blamed for doing that. The second area is around building expertise, and this is not only ensuring that providers and services have access to the right expertise, but also our internal staff. You know, we have a lot to do in terms of making sure our operational teams understand how safety is changing, and you know, we want to move from that more transactional approach that I think you quite rightly say CQC have sometimes had in terms of, you know, checking fridge temperatures and such, to be having that kind of more mature conversation and regulatory partnership with providers. Involving everyone is about making sure that people who use services are equal partners in their care, and as I say, kind of you can really see the impacts of that within PSIRF. Regulating safety. Well, safety is, of the 5 key questions, it's the one where we've always had the poorest performance. If you look at our ratings profile for SAFE, and we know that some of the greatest safety risks happen when people either struggle to access the right care or when they're transferred between services or are discharged. And we know also that some services have a greater safety risk than others, so that new regulatory model is a bit more flexible, and it allows us to put more resources into where the safety risks are greater. And then lastly, kind of consistent oversight and support. So to improve safety, we know that providers will need support and guidance. And there are some sectors, and I think I'd include hospices in this by the fact that we have these lunchtime learning events. There are some sectors that have quite a lot of support. NHS England, with their sort of team of safety experts, certainly give a huge amount of support in that sector. I guess maybe hospices are probably middling around that. And then adult social care, who by volume is by far the biggest set of providers that we regulate. Actually, there's no national bodies to support them in improving their safety. So kind of what role does CQC have there? Is it different to where we have it to what we have in different sectors, for example? And what I've done, I won't read them all out, but I've just picked out some of the key strategic commitments from across those 5 areas that link to the ethos of PSIRF. So, for example, learning improvement must be the primary response to all safety concerns in all types of services. Obviously, there's a really clear link across to PSIRF there. Right, if you could go on to the next. Oh, you're on it. Don't worry. Stay there. So some considerations for hospices. So I guess just before I go into the kind of the details, some things that I'd like to highlight. So there are some considerations around PSIRF that are relevant to all providers, and that is that it's a significant change for you all. I know Tracy Herrley and her team, NHSE, who have developed and implemented PSIRF. She says it's a journey, not a framework, and it's not that anyone expects providers to, on whatever date it may be, all of a sudden, be able to completely meet PSIRF. It's going to take a huge amount of cultural change in your providers as well to really understand kind of what PSIRF's trying to achieve. It's also a very significant change for my operational colleagues, and they won't have all the answers, and it makes them very anxious. If I'm honest with you, they're quite used to having a neat 72-hour report following a serious incident, and then a root cause analysis report within 60 days of that. And that doesn't exist under PSIRF, and so I'm sure you can kind of appreciate that causes some anxieties for our colleagues who have been used to having those types of documents and being able to use them as assurance that providers are managing risks appropriately. And add to that, you'll probably be aware that CQC is going through really significant change itself. Not only have we restructured all our teams, we've got the new regulatory model starting to roll out towards the end of November. So we're kind of running 2 models at once. How we manage PSIRF across that is a bit challenging at the moment. And then there are other concurrent changes, such as the move to learn from patient safety events. I'm going to be honest, I don't know whether LFPSE is relevant to hospices, but again, that adds further complexities, and there's lots of confusion, I think, as to LFPSE, which is about reporting events, and PSIRF, which is about responding to them. Sometimes I get queries that are labelled PSIRF but are actually about LFPSE, for example. And then there are some hospice specific considerations, and I think the big one is the various commissioning arrangements and the impact that has on the provider level development of the PSIRF, the plan. This hasn't changed in the new model. It's how CQC have always done things, but in NHS trusts, for example, we have, as well as looking at individual services, so whether that's critical care or the emergency department, we have an assessment of well-led at the trust level, which just looks at the well-led key question. We don't have that in any other type of provider. So where you've got kind of a small, like a single location hospice, for example, we can ask those questions about your PSIRF when we look at that, when we look at that location. But it for the larger providers among you, something like Marie Curie, I guess, I'm presuming that you're setting your plan at that level, but we don't assess you at that level. We only assess you at the individual location level. So kind of how we work through that, how we make sure that I guess that those locations are given a chance to input into the plan, for example. So it's a slightly different way that we have to try and approach it. So I guess the kind of overall aim of this slide is to give you a little bit of reassurance that CQC is not going to come in and say, you know, on a certain date, or you're not doing PSIRF properly. We do understand that this is a big change for you and for us. If you could go on to the next slide, what I wanted to do over the next few slides is just use the using a single assessment framework, explain how PSIRF kind of fits into that, which I hope will also kind of explain the single assessment framework itself a little bit. So on this slide, you'll see that the 5 key questions quadrant of this sort of little infographic circle is highlighted. So the 5 key questions, which I know you'll all know and love, safe, effective, caring, responsive and well led, they remain in the single assessment framework, as does our rating system. A big difference of the single assessment framework is that it applies to all types of services, all types of providers and at all levels. So whereas previously we've had a health assessment framework and an adult social care assessment framework, and then for each of those we've also had a framework that we use when the provider registers with us, and then a different framework that providers use when we go out and assess and inspect them. The single assessment framework is one framework that covers all that, and it's also applies to the work that we're doing around local authority assurance and integrated care systems. So to that extent, it's had to be written in a way that's reasonably generic, but hopefully over the next few slides I'll be able to speak through then how that's applied into a specific type of sector. So those 5 key questions, they are aligned with I statements. We've done a lot of work with organisations such as Think Local, Act Personal and National Voices to articulate what those 5 key questions mean for a service user. Right, if you could go on to the next slide for me. So sitting under the 5 key questions, whereas currently you've got our CLOEs, our key lines of inquiry and prompts, and there are pages and pages of them. They've been replaced by a set of 34 quality statements. They're pitched at the level of good, and they're also linked to the regulations that help us make our judgments about the quality of care. So I've picked here, because it's very pertinent for PSIRF, the quality statement around learning culture, which is actually a new kind of, I'm going to say we didn't have quality statements before, but there was no previous CLOE that was focused on learning culture. You can see it's been written from the perspective of the service provider. So, and it says we have a proactive and positive culture of safety based on openness and honesty, in which concerns about safety are listened to, safety events are investigated and reported thoroughly, and lessons are learned to continually identify and embed good practices. So as I say, there are a total of 34 quality statements. But it's really important to say, and I'll probably say this again when we get to the evidence bits, the change isn't about overhauling what we look at in our assessments. It's not that suddenly we're going to go and look at, you know, a whole range of different evidence that we didn't look at before. It's about streamlining much of the duplication that existed within and across the CLOEs, and it is about strengthening in some areas. So, for example, the quality statement about learning culture. So it makes things clearer for providers as to what our expectations are. And as I say, that each quality statement is now linked to the relevant regulations that impact on this quality statement. It may be in their entirety. So, for example, duty of candour, really the whole of that regulation is relevant to learning culture. It may only be parts of it. So something like Regulation 12, safe care and treatment, is such a huge regulation that maps to many quality statements, but it's different parts of it that might be more pertinent to a certain quality statement. And if you could move on to the next slide, this then underneath our quality statements are evidence categories. And we've gone down this road because we want to be more consistent and transparent in our approach and how we make judgments on quality. So to address this, we've developed a way to categorise and score evidence as part of our assessments. And those evidence categories will bring more structure to our process for assessing quality. So there are 6 evidence categories. They're listed there on the screen. They're all weighted equally where we've got evidence in them. You may know that we've recently published, I think in the last couple of weeks, The quality statements that for the evidence categories that for a certain quality statement would always want to make sure we've got information in them before we make a judgment. There are some reasons why we wouldn't use a particular type of evidence category for some quality statements, and some of that is kind of a really generic. If you look at something like a domiciliary care agency that we regulate, we have no legal remit to go into people's homes. We don't observe their care, so observations is likely to be used very minimally, if at all, in that type of service, for example. In others, outcomes of care, we have quite a lot of outcomes for acute trusts, etc. Not so much in other types of services. Might be that we use evidence in outcomes less for some of their quality statements. People's experience is a really key one that reflects, again, speaking about that strategy and the kind of one of those aims being, making sure that we're regulating in a way that reflects people's experience. People's experience is one of the evidence categories that is pretty much mandatory, I think, across all quality statements, that we get people's views on the care that they're receiving. And then if you could just go on to the next slide, this is the last one of this single assessment framework. Within those evidence categories, you've then got specific evidence and quality indicators, and they will vary from sector to sector as well. So one of our evidence categories is around feedback from staff and leaders, for example. And that would pick up things like, having focus groups or individual, interviews, discussions with staff members, for example. And then in some sectors, you've got like the NHS staff survey, where there are specific questions that we can link to a quality statement. So again, using that learning culture quality statement, there are questions within the staff survey about how able staff feel to report incidents, whether they ever feel discriminated against for doing so, etc. So an individual question from that staff survey we'd be able to map for providers who are captured under that staff survey, and in others that there would be different types of indicators that we're using. So there's the evidence and the quality indicators itself will vary from sector to sector, even though the single assessment framework as a whole applies to them all. And then you'll see just around the outside of this circle, it says underpinned by best practice standards and guidance. And again, that's going to vary from sector to sector. So there is some best practice standards and guidance that does apply to all. So, for example, we've got a quality statement around infection prevention and control. There's a code of practice around infection prevention and control, which would apply to all services. However, there are then other bits of guidance, and PSIRF is one of those that doesn't apply to everyone that we regulate. So PSIRF is not mandatory in adult social care. It's not mandatory for primary medical services, for example. I think we think it's a good thing if they use it, and we know that some are starting to use it. But it's not mandatory for those types of services. Yeah, I think that's probably all I need to say on that slide. That's fine. Okay, so if we can move on to the next one. I'm on to my I think my kind of fourth area, which I wanted to speak about, which is around the patient safety incident standards, response standards, and kind of what CQC's oversight role is. So hopefully you'll know that there are these patient safety incident response standards that ensure that organisations meet the minimum expectations of the PSIRF. They cover 4 areas: policy, planning and oversight, competence and capacity, engagement and involvement of those affected by a patient safety incident, and then proportionate responses. And then within those 4 areas, you can see there are kind of 17 different areas. So I'm sure you're aware of this, but these are not CQC standards. These are the standards that are in PSIRF that has been developed by our colleagues at NHSE, but we then use them in our assessments. So what I'm going to do is I'm just in a couple of slides, I'm just going to pick up on a couple of these to kind of talk through how we envisage our approach working. If you can move on to the next slide, just before I get into that detail, this slide, it comes from the document that's called PSIRF Oversight Roles and Responsibilities Framework, and it articulates the ask of CQC in relation to PSIRF, but doesn't give a huge amount of information. It certainly doesn't give a huge amount of information compared to the oversight roles of other types of organisations, whether that's the provider board or the ICB, for example. So I've been working with colleagues at NHSE, Tracy Hurley in particular, who you may know, to kind of think, well, what's the types of questions then that CQC need to ask in order to be able to assess a provider's implementation of PSIRF and how they're getting on with it. So if you can move on to the next slide, this slide is an animated slide. So if you can just press once more, that's it. So this is about the plan standards. So this falls under the opening area, the policy planning and oversight part of PSIRF. One thing to say, this has been written with an NHS trust in mind initially. So some of the specific types of evidence listed here would need to vary for hospices, but I'm sharing it with you in the hope that, as I say, it articulates kind of how we're intending to go about this. So the overall standard says our processes for developing, maintaining and revising the organisation.
I might switch to the Hospice UK PSIRF and CQC one.
Oh, I've got a bit of background noise if we can go on mute. Thank you. So our processes for developing, maintaining and revising the organisation's patient safety incident response plan robust. So some of the things that we would want to be assured of under that are, have appropriate stakeholders been identified and involved in the development of the plan? What type of data has been used, both quantitative and qualitative, in the development of that plan? Does it reflect the data review during the plan development? Is it clear how the organisation has actually selected their learning response priorities? Is it reviewed? And certainly in the early stages of PSIRF, you'd probably expect that plan to be reviewed on a, I don't know, I guess probably an annual basis. There's no standard that tells you how much it has to be reviewed. But in these early stages, I suspect an organisation would want to review that reasonably regularly. Maybe, 5-10 years down the line, it'll need to be reviewed, on a less regular basis. Does the risk register, for example, reflect the key themes that are highlighted in the plan? If you can just press the next button. So what I've tried to do then is then kind of link how our evidence categories might be used to organise our evidence here. But as I said earlier on, we currently have two different models operating, and it's got to be suitable for both as we transition providers across to our new regulatory approach as well. But we might want to speak to those who use services. So what does that mean? Well, it's certainly in an NHS trust, there's something called patient safety partners. So we'd probably want to speak to those. Clearly, obviously, local patient, family, carer representative groups. We might want to speak to the local health watch. Also falling into there would be any surveys that the provider or the service themselves has done for their patients and service users that would have, that they could submit to us as evidence. If you just go on to the press, that's it. So there's another evidence category around feedback from staff and leaders. So who would we want to be speaking to here? Well, certainly the board, the executive team, or whatever the appropriate terminology is if it's not an NHS trust. Is there an executive lead for PSIRF? We'd want to speak to them. A patient safety team, again, depending kind of what type of organisation you're talking about. Certainly in a big NHS trust, you'd expect a patient safety team. That might not be the case in a much smaller service like a small hospice. The patient safety specialist, which is a dedicated role to kind of lead on safety in an organisation. Maybe the improvement team if there is one. And then if you could just press again to bring up the next box. What feedback could we get from partners? So we might want to speak to the ICB, their patient safety specialist, their PSIRF lead, to get their views on how the organisation in their patch are getting on with implementing PSIRF. And then lastly on this side, kind of the processes. So what are the types of things that we could ask to look at that are more kind of process driven? So incident response policy, the incident response plan should be on the internet sites of the organisations. We might ask for minutes of relevant PSIRF meetings. There might be something like a patient safety committee or a response review group. Just to kind of get a caveat that we know that the names of those meetings that are not going to be the same in every organisation. We're just trying to articulate the types of things that they might be called here. Might be that we go and attend one of those meetings and observe it as well as looking at minutes. Risk register extracts and also board papers, for example, where the PSIRF is referenced, just to see, is that articulating that the board are actually involved in this process and understand what it's about. This is an interesting one, an interesting example to use, because you'll see here the challenges that we might have in assessing that in provider types where there isn't the provider level assessment. So we'll need to think through some of these questions. The sort of lens of them might need to be slightly tweaked to be asking, a specific location. So a specific hospice, how have you been involved with developing the PSIRF? In order to be able to test the provider processes there. And then if you can go on to the next slide, this is similar, but looking at competence and capacity. So there are loads and loads of standards for competency and capacity and the training requirements. So I haven't listed them all here. But the types of questions that we would want to be able to answer, a lot of those requirements being met. So there are separate ones for learning response leads, for engagement leads, and for those in the provider oversight roles. So has the training been completed, and has that training been provided by or in line with the requirements of it needing to be someone on the PSIRF procurement framework, for example. I wonder whether this might be one of the things that comes up as one of your concerns about PSIRF. Is we know that currently there is not enough training out there to meet demands. So it's not that we expect everyone to have been trained by X date, but if those training needs aren't being met, what plans have you got to meet them? Have you got any mitigations in place to ensure that incident response quality remains of a high standard? So that it's very different, isn't it? If we were to go into a provider who sort of gave us a blank look and said, what training requirements? That's very different to going into a provider who said, oh, yeah, we haven't done this bit yet, but this is what we're doing to try and mitigate that risk, even though the outcome is the same, that neither of their staff have potentially had that training yet. Would be much more assured in the second case that provider understands what's required of them and is thinking about how they can meet those needs going forward. And if you just press up again, so in terms of, again, who we might want to speak to, where we could gather evidence from in terms of staff and leaders, again, the board executive team, the PSIRF executive lead, quite similar to the ones around the plan standards, really. And then if you just one more, I think, on this slide, which is processes. So these are quite different. So again, we might have access to the electronic staff record, for example, where training records are recorded. But if not, what other training records are there that we can use as evidence that that training has been delivered and carried out? What's in the PSIRF policy about meeting them? Is there anything in a kind of overarching mandatory training matrix that we can use as evidence there that a provider understands what's required of them here? So I hope, where are we now? I hope that's been useful to kind of give you an overview. So really now it's over to you. Happy to have a bit of a general discussion. I'd in particular be really interested to hear if there are certain standards that you've got concerns about meeting. What I'm going to do, I'm just going to put you back over here on my main screen so I can see people.
Claire, thank you so much for that very comprehensive presentation, and certainly taking us through the new approach, the new single assessment approach, and applying that to PSIRF and what that means, what that means. But I think also very much acknowledging a journey, not a framework, and also, as you were sharing with us, that you know, that variation in how services are commissioned. So actually it's not something which is mandatory for all hospice providers. And actually that is one of the comments that's in the chat box, which maybe we'll come back to in a minute. But I think, you know, picking up on that whole focus around culture, learning and improvement, so important, isn't it? And I think, you know, for again, what you've given us, I think it's some really clear slides there about, you know, your thinking, again, whilst acknowledging actually that it's a journey for all of us. So I'd love to open the floor because I'm sure there are lots of questions, and I don't know, Francis Hammond, if you'd like to make a comment just on you know, on that point about the variation in commissioning, because I think, you know, the point there is very much actually about hospices, you know, may not have that NHS contract or be commissioned in that way, but actually many will be adopting the methodology as a, you know, as a way forwards in terms of, you know, learning improvement and safer care. So I don't know if I can see Francis. Welcome.
Hi, thank you, Anita, and thank you, Claire. That was really helpful. It was lovely to see where the CQC's thinking is on this. And I suppose it was just that point. So I've met other colleagues on here before, but just to reiterate, I've come from an acute trust in Plymouth and I now work in the hospice. So I can see very different sector. The level of risk is very different. The quantity, the volume, the types of issues we're dealing with. And I guess from where we're sitting in the hospice, we actually don't have a standard NHS contract. We get a grant. So in terms of the PSIRF regulations for NHS England, we actually don't have to do PSIRF. We don't have to adopt it. Historically, for many years, we have adopted a very human factors-based approach to patient safety improvement, safer care and improvement. So in terms of this new approach, we're absolutely behind. We think it's the right way to go. But I guess I'm just aware that if our CQC inspector would be going, why haven't you got all these things? And we'd say, well, actually, theoretically, we don't have to have them. So, and whereas another hospice in another part of my region may have a standard contract. So it, you know, I think in the same way you said GPs don't have to do it, but you know, it'd be good if they did. So will the CQC take that into account, that you might be looking for things which we don't necessarily have to have in terms of NHS obligation?
Yeah, certainly, and you're right, you know, just like in other areas where it's not mandatory, we think it's a good thing. So we'd encourage all providers to use the principles whilst acknowledging that those principles might not necessarily fit, you know, those services that are for which it's not mandated, but you know, they're kind of involving those who have been affected by patient safety incidents, you know, the kind of proportionate learning responses, the fact that learning would be the primary response, you know, and it's separated from that kind of from any blame apportionment, etc. Kind of really, which is why I kind of started it with our strategic objectives, really fits in well there. In terms of, so I spoke a bit about the quality statements. We're in the process of developing the underlying guidance that sits there, and that will need to make clear, you know, the services that it's mandatory and the services that it's not, but we consider it, you know, we would consider it good practice to use. And you know, I've been doing a lot of work with our internal colleagues in terms of providing training in team meetings and that to kind of articulate that as well.
Thank you, Claire. Well, I can see Judy. Hello, Judy. I can see your hands up. Would you like to come in?
Yes, please. Hello, everyone. We have met with a local ICB. We've had a couple of meetings with them, and what they've said to us is that it's not a tick box exercise. It's about looking at safety through a PSIRF lens, which is helpful, but not helpful. And I was just wondering if, I mean, I'm only saying that because we're still trying to work out exactly what our responsibilities are. And I just wondered if other people have been in touch with ICBs and, you know, what feedback that they've had.
So thank you for that question, Judy. And it might be good if people wanted to pop something into the chat box on that, because we've got lots of hands going up and just would like to try and get to everybody's questions. So thank you, Judy, for posing that. And again, that is, you know, it is that, isn't it? It's about how we're implementing the change. Jenny Wood Gallagher, would you like to ask your question? Because lots of hands coming up.
Yeah, sorry, I'm having problems with my camera, so I've turned it off because I keep losing connection. Jenny Gallagher from Bolton Hospice. Yeah, ICB, it's been mentioned briefly and at locality level. It hasn't been specifically mentioned yet. And I guess my comment really is along the lines of everybody else. We know that hospices, I'm not saying we should be treated any differently, but this isn't mandatory. It's recognised as best practice. We know that hospices across the country have got massive financial deficits and are going to be potentially looking at cutting services. And I'm just not sure how we're going to be able to resource this. That's the first point. And obviously, hospices operate at different levels, and you will get some good and some not quite as good, you know, across the board. But I think in general, that is the approach that hospices tend to take to managing incidents. So it might be that we've got a lot of the background, but we will evidence it in a different way. And I just feel that this is going to be, and for those organisations that already do work in that way, this is going to be considerably, it's a huge amount of work if we were to try and adopt this with the training and teaching, when we will already have stuff that will align with all of this. Does that make sense? I'm just concerned that this is another thing and there's no money and no resource behind this. But if we're going to be potentially penalised because we haven't adopted this way of working, and yet GP practices don't have to either. So I'm a little bit, I suppose, a bit frustrated really. I get it, it's about patient safety and learning, and I feel that we do have that approach here, and we are very transparent and open with incident reporting and sharing learning. So in some respects it won't be a massive amount of work, but it is going to be a degree of work when resources are already stretched and there's nothing coming from central government to support the implementation of this. Sorry, I just feel really frustrated by it because this could be quite big. Thank you.
Thank you, Jenny. Thank you. And yes, I mean, I don't know, Claire, if you want to come back on that.
Yeah, so I guess on the ICB approach, I mean, I've just been seeing the kind of some of the messages flick up. Again, I'm not an expert in them, but I'm aware from some of the kind of conferences and other events that I've attended that some are further down the line and in a better place, shall we say, to support all the services in their patch. So I think I'm right in saying London, have taken sort of quite a rigorous approach to PSIRF, for example, whereas others are, you know, not so far along with that journey that they're also going through. I think in terms of the resource, I mean, yeah, I mean, I'm not here to defend PSIRF itself. I mean, I think to an extent part of it is about making sure that you're directing your resources to where there can be most learning. But I do appreciate that right now at this point it feels like, oh, we've got to do a policy and a plan and all this stuff. That feels like it's a lot more work. On the training side, I mean, again, it may be something that your ICB can help with in terms of, can they provide some some support there. It doesn't have to be that an individual organisation, because some I'm sure this applies to some hospices, it certainly will apply to some types of services, are so small that there's no way you could have your own patient safety incident response lead, or certainly not perhaps to the level set out in the standards. So kind of, again, it's about that kind of, what are you doing to kind of think about how that can be provided. It's not saying you must provide it on your own in your organisation, and that will also help with that kind of systems learning as well is kind of a real key aspect of PSIRF, isn't it?
Thank you very much, Claire. Helen, you've patiently had your hand up for a little while. Would you like to come in?
Yeah, I think my concerns are very similar to what's been mentioned already. I think, you know, we've got a 0% uplift on our grant, and it's where we get the money to fund these. So it's not that there isn't a will there to do it. We very much want to do it, and it's what we're probably ingrained in what we deliver. But I think, you know, the person that will do this is probably going to be the health and safety lead, the Codicot guardian, the CSIRO. It's that level of not necessarily sort of prioritising our resources. It's all those statutory roles that have to be picked up by what is often a very small team, you know, that you've got involved, so that it can't be a particularly specialist role from that point of view. So I think my concern is about the proportionality of how this gets inspected, really. You know, when you see all those things that, you know, you're saying we've got to have somebody, an exec, that takes responsibility for this. So our exec board are all volunteers, so they're going to have to so we're going to have to find somebody. We've just had to find somebody to be the freedom to speak up guardian, and it's just that level of pressure, really, that I think we're feeling to meet these needs. And we want to be outstanding as an organisation. We get told regularly our care is outstanding, and we know we have to deliver on the governance side to be outstanding as well. So yeah, I don't know if there could be like guided specific hospice PSIRF that isn't at the level of a big acute hospital even.
So I know that Tracy and the team at NHSE have been working particularly with small independent, albeit acute services, to try and work through what a more proportionate approach might be for them, for example. And I would suspect, I haven't seen anything published around it yet, but again, I would suspect that any principles in that, you know, that could be widened to kind of smaller providers in general. And from a CQC perspective, we'd really welcome that, because otherwise it's down to us to say, well, you're a smaller team and this is proportionate, you know, and a different, you know, it's very difficult without that kind of shared understanding of what's proportionate for us to then take a consistent approach. But I can certainly, Helen, I can certainly speak to Tracy, who I speak with very regularly, around, you know, is there something specific that can be either that bit of work for the small independent acute services being extended so that it's relevant to hospices, or you know, whether her team are doing anything around hospices more generally.
I think that'd be good, because I think if you're looking like private acute hospital, they can put that in their costs, can't they? As a charity, we can't go out to our supporters and say, please, can you fund a PSIRF person? They want to fund patient care, you know. So I think we've just got to look at it from that point of view. So I'm not asking for special treatment anyway, just to sort of look at how we deliver it a little bit more effectively and efficiently, maybe.
Thank you very much, Helen. I'm going to just move across now to Hilary, and then Julia. There's lots in the chat box. You've got your hand up as well. Do you want to? Is there something you want to comment? No. So perhaps come to Hilary, and then Julia. Can I come across to you, because there's lots of conversation in the chat box, and I think some of what's going in the chat box, trying to keep an eye there, is some really helpful conversations about how hospices are working together and working in ICB. So Hilary, would you like to ask a question?
Yeah, I mean, I've sort of previously worked in CCG land and used to sort of deal with STICE reports, and my understanding was PSIRF was the successor to the Serious Incident Reporting Framework. And one of the things that we've struggled with here with the PSIRF is we don't have serious incidents on a regular basis. We hardly ever have them. So actually trying to create, you know, something to present to you as here we are doing PSIRF is very, very difficult. And it almost feels as though we're investing a whole lot of time and energy and resources, people as to say, when we don't have really anything that, you know, the intention behind it, we can't fulfill that. So then we've sort of got to go to the next level and look at our other patients, almost like routine patient safety incidents that everybody has and reports onto Hospice UK. But even then we're struggling because numbers are so small, certainly in our small hospice. And I do worry about the fact that you're going to be assessing us really sort of coming from the acute world, not realizing it's a whole different world in a hospice. And if you might come one year and we might have no serious incidents, which I think we went for 3 years, no serious incidents. Yes, we can show you what we've done on, we'll try and have a PSIRF plan around, say, falls and pressure ulcers. But considering we have those all the time, year on year, and we implement as much learning, I'm not sure we're going to get the sort of benefits that the national system thinks we're going to. You think we're going to do that. And I think there's more that we can certainly demonstrate a learning culture, and we've been assessed as doing that. But for all of this and implementing it all, I mean, just the language from that presentation, when you're talking about patient safety team, I'm not sure that hospices have patient safety teams. We don't have that resource. So I think it's got to be scaled right back and a completely different approach. And I think that needs to be taken back to your sort of management, and if necessary fed back, and certainly get more from NHS England about how it's going to apply, because we can go through the motions, but whether we're going to get the intended benefits, because otherwise it'll just become a tick box exercise. You know, we'll do something, it'll probably pass muster, but at the end of the day, if we're not going to get out of it what the original intention, I'm going back to what PSIRF was originally about, which was serious incidents, which I used to see on a daily basis, and really engaging with the people affected. I'm not seeing it as being very applicable in our world. It's going to be much more of a struggle to make it fit without it, you know, sort of becoming a bit of an artificial process. I know that sounds negative, because I'm all for learning from incidents. And we're doing that, and we do as much as we can, but it's, you know, it just feels, I can't see how it's going to work as it was originally intended in a very small hospice. You know, and you've got to remember, like, we've got 10 beds.
Yeah.
You know, an average occupancy of 8 beds. So it's thinking about that at the core of it when we're thinking about such a big system, new system.
Hilary, thank you very much. I'm sorry to interrupt you, but I'm very conscious we've probably only got about 4 minutes left. So very quickly, Julia, is there anything from the chat box you wanted to highlight? Because there's been lots of discussion in there, hasn't there? And we will certainly be collating the information, sharing it back with you as well. So Julia.
Absolutely, absolutely. And thank you, everybody, for your great questions. The chat box teeming with things in it, primarily, as we've discussed, variation with ICBs. So some people having really good relationships and support, other people not so, which I think we've discussed before, but and I think Claire was cognizant of that as well in her presentation. I think the other big thing that's coming up in the chat is about training and accessing the training, and HSIB are providing it to NHS colleagues, but it's difficult to access that, or nigh on impossible, to be honest, if you're in a hospice. There's a bit of a shout out to Hospice UK to see if we can help with that. And we'll certainly take that away and see what we can do. But obviously, no promises. We have been in touch with HSIB in the past about this. And I do know there's as Claire's alluded to as well, there's a lack of resources for training. Some people have been getting training from their ICBs, which is another way to look at it. And I know some localities are also clubbing together and contacting private providers for training, and that way, if they club together, they're reducing the price of it as well. So there are ways and means, and do have a look on our PSIRF channel. I think Stuart's put some details if you want any more information on anything to do with that. I'm just ICB's given us leads, accessing training. Yes,
Okay.
Jenny made a good point about tagged onto someone else's role, and I think we're cognizant of that. And the buzzword, as we've heard today, is proportionality. But what does that actually mean in practice is another difficult one. I'm just
Julia,
scrolling.
thank you so much. We've
Yep,
got 1 minute left, so I'm
that's
going to
okay.
just
Go for it.
yeah, thank you so much. I mean, I think I just wanted to kind of, I suppose, yeah, I mean, and there are so many questions. We are starting that journey together, and I think we're all learning together. And I think something you said earlier, Claire, which I thought was really, you know, that is helpful, really helpful for us. You're talking about, you know, CQC's new approach is very much about moving from that transactional to, you know, that participation, regulatory partnership, I think you said, and so it is about that conversation. It's about us learning, it's about us understanding, and actually on this journey in particular, the considerations of the sector and the sector needs, and some of the questions that have been raised today, which I know that, you know, you'll be considering as well as we will. But equally, thank you so much for all colleagues that have popped into the chat box how you're starting to take this forwards. For some of you, it may be, you know, spot who's local to you, who's doing something on this, who you might be able to help, you know, and share together, because I think, again, that collaboration is going to be really key in this, isn't it? And supporting. And I think, you know, building on that philosophy of safe care, which actually everybody is saying this is at the heart of what we do. And so, you know, I think keeping that core and that learning culture core to what we're doing. So thank you so much, everybody. We have come to the end, but if you are able to stay for just 2 more minutes, I would just like to invite Stuart to put a short evaluation poll up on screen so that we can just take some feedback from you. And in the meantime, we have put the information about the PSIRF channel into the chat box. Julia, I know, would be really pleased to hear from you after today's session, and of course we would be pleased at Hospice UK to continue to support this really important agenda through the patient safety programmes. So you know, this is the start of a conversation, and something that, you know, we want to be able to support you with in the best way we can. So just give you a few minutes and to say thank you very much to Stuart and Amber, and to Julia, and especially to Claire for joining us today and sharing your presentation. Claire, thank you so much for your time you've given to us today with sharing CQC's perspective and as we're starting this learning journey. So thank you very much, everyone. I'm going to just leave that on screen for just a couple of more minutes.